Hello everyone, my name is Caitlin Murphy. My presentation is Alcohol Withdrawal Protocol, A Need for Change. So the company I work for is the Olathe Health. It serves 4 counties with multiple clinics and has 2 hospitals. I work in the Olathe Medical Center, it's pictured in the lower right. And then they also have a Miami County Center in a different county. So the Olathe Medical Center is a 300-bed acute care hospital. It opened in 1953 as a little 30-bed hospital. Even now, it is continuously expanding as they just finished the birthplace, which is the upper right picture, a few years ago. And then recently, just beginning of this year, they opened a new cancer center. It is a certified stroke center and a certified chest pain center. A majority of our patients are, in fact, chest pain, heart surgery patients. So it has many different areas. There are med-surg floors, telemetry floors. There's the ICU, and then there's the PCU where I work, and that's the main unit for this project that this will be focused on. So it's the progressive care unit. It's basically a step-down ICU. The main patient load is cardiac surgical patients and lung surgery patients. So we get a lot of thoracotomies, post-op day 1 CABG patients. We also get a lot of DKA patients, patients who require to be on insulin drips or have to be on a BiPAP. We don't really deal with the ventilators, that's more of the critical care unit. But we also will do like stable septic patients. It's a 15-bed unit, so it's not huge, but keeps us pretty busy. So the mission statement for Olathe Medical Center is to improve the health of all individuals in the communities served by giving compassionate health care with trust and collaboration. There is no specific religious affiliation. We do have like priests and pastors who will come visit patients if they would like to be visited, but it's not a Catholic hospital or anything like that. And then we show culture in our care. We have lots of interpreters. Kansas City, as you know, also has a wide variety of like a deaf population, so we also have employees who are able to do sign language to communicate with them as well. So how is this incorporated into our nursing care? As you can see here, I mentioned a few things. There's all the different specialties. We have our patient ratio is 1 to 4 at night and 1 to 3 on days. Patient advocacy, administrators open to practice change, trial runs, and then like the free education classes. So all this goes back to our mission statement of giving the best compassionate care by collaboration. That's where the specialties come in. They are constantly encouraging evidence-based practice, so this is where the free education classes come in. Ratio is one of the best in the hospital on my unit because of the acuity of patients. Some situations like the insulin drips, DKA, cardiac drips, take the ratio to only 3 patients at a time at night just because they require more work and more care. It also reflects the mission value by trust in nursing staff and the physicians by allowing more time with patients. So the patient advocacy, on PCU we are pretty good at fighting for a patient's needs and being their advocate, whether it's for medications the patient needs or clarifying code status with the case manager, things like that. And then, like I mentioned, administrators are very open to evidence-based practice change. So the unit managers, floor managers, they're always listening for new ideas and are open to helping find solutions to problems. The hospital also has a librarian whose main job is to find research articles, to look up things that we are needing to be able to find, to implement new evidence-based practice changes. So that's very nice. So the issue. 20% of ICU admits are from excessive alcohol use. Statistics show that over half of Americans aged 18 and over are alcoholic drinkers. 50% of trauma patients also indulge in alcohol on a frequent basis. This leads to high risk for symptoms of early alcohol withdrawal symptoms. So as you can see from my beginning slide, alcohol withdrawal protocol is what I'm focusing on. Alcohol withdrawal is very hard on everyone involved. It's hard on the patient. The symptoms are not pleasant, and if allowed to go on, then they can become very serious and harmful. It's hard on the family to watch their loved ones go through this, especially if it's something that they've seen before or haven't seen at all. And it's also hard on the staff. Alcohol withdrawal patients take a lot of time. You're constantly assessing them, looking at them, trying to decide what would be best for that patient. When alcohol withdrawal is not recognized or monitored correctly, it can easily turn into a very serious life-threatening condition. So they can occur anytime from 12 to 24 hours after the last drink. Now this is for very serious drinkers. For those who just have an occasional drink, you're going to go into the hospital. It's not going to be that big of a deal. But for those who drink daily, drink a lot, going into the hospital seizes that alcohol intake, and it's really, really hard on your body. So we do have an alcohol withdrawal policy for monitoring the alcohol withdrawal symptoms, and then as needed medications to give them when symptoms reach a certain level. We currently use the CWA assessment, the Clinical Institute Withdrawal Assessment. Depending on how they are reacting or how their symptoms range, it's done from every 15 minutes to every hour. If they're not having any symptoms, then it'll go from every hour to every 4 hours for so many hours, and then if they're still not having any symptoms, then it'll just be once a shift, or we'll discontinue it after a little while. Because once they get past that 24, 48 hour mark, and they're not showing any symptoms, they're more than likely not going to. So the problem right now is alcohol withdrawal admits at OMC, or Latham Medical Center, have had an increased number of patients who are admitted to telemetry floors, or even PCU for instance, and then are having to be transferred to ICU for sedation and intubation, because either they're not getting the medications, or something is happening to where the medications aren't working correctly, and so they become super restless, super agitated. They start becoming harmful to themselves, start having respiratory distress problems, so they have to go down to the ICU. And this is a major problem. So a couple of the questions, is there a lack of education regarding correct use of policy? Are nurses scared to give the medications when they're supposed to because the symptoms don't seem bad enough yet? Are doctors ordering all the medications that they can? Are they using the policy to full extent? Do the nurses need clarification from doctors about, are you always wanting me to give the medications? Are you wanting me to hold it for certain things? It seems to be there's either a communication error, or there needs to be a policy change or something. So past feelings, they did add phenobarb after several studies, and they saw that it will help with when severe symptoms are starting to occur. And this was added because it does manage the symptoms better, but does not cause the respiratory depression problems. And then they have gotten to where instead of going to floors that have, 5 patients apiece, they will go to PCU where they only have 3 or 4, or a different unit, but those nurses won't take as many patients. So they are trying to put the patients on units where they might have better monitoring to be able to, catch this problem before it becomes a problem, but it's still occurring. So the social impact, patients going through alcohol withdrawal, they cause stress on themselves, the people who are caring for them, they might be dangerous to themselves. The doctors they're very upset when their patient has to be sent to ICU and sedated, because it shows, either they missed something, we missed something, something just wasn't working like it's supposed to. Pharmacy is very willing to help look for change in medications or protocol. I actually had one of my nursing supervisors come up to me because I was trying to figure out a project for this, and they talked about how, they themselves were going to start looking for some type of, some type of solution, whether it was different medications, different doses of medications, or anything like that. And it also just creates a very tense atmosphere on the unit where this person is, especially when they're agitated, yelling out. It'll distract other patients. It can make them agitated. So it's just very negative on the social environment. So what are some strengths? We have very good cooperation within the nursing units by staff. Help is always available. So when we do have problems or we can't get in to see a patient because of something else happening, we're very good at helping each other out. Managers and administration, they're very open to discussion of problems and possible solutions. My manager is actually my preceptor, and we've been talking about this project now quite a bit, trying to decide what would be a good solution. And then they're very good at using best evidence-based practice when implementing new changes. And an example of this would be Zyprexa has now been added to our protocol also, if the physician chooses to do so, and that also helps with the agitation and restlessness. Weaknesses. So while the administration is very good at, asking for change and stuff, they're not always very well at communicating it when it does happen. It might be just a simple email or something that just doesn't really communicate, like there's no communication. We also have a high majority of older nurses, and so they're very, very resistant to change. Protocols might not be as big of a deal, but major changes could be. They won't want to do it like they're supposed to. And then education is not always provided on policy changes or problem areas. So while they're opening to listening, they might make the change, not communicate about the change, and then they might not educate about the change. So this can become a problem too. So my recommendation is the implementation of a PAWS scale. So PAWS, as you can see, stands for Prediction of Alcohol Withdrawal Severity Scale. It is the first validated prediction tool for alcohol withdrawal symptoms. So you have the CWAL, scale that you use to assess the severity of the symptoms, but that can only assess what is already there. It cannot predict if they're going to start having some very complicated alcohol withdrawal symptoms or not. So the good thing about this scale is it allows for prophylactic treatment before complications arise. So if you know this patient reaches a certain criteria, and they might have complicated withdrawal, then you can start treating them prophylactically, whether it's just, having scheduled Xanax or, just other medications to help keep them calm, help prevent them from even getting into complicated AWS and just having, mild symptoms that are very, very easy to treat. Several studies have shown the sensitivities in positive, negative, predictive values are 100% with a threshold of 4. So that is very, very good. It's showing that those who are saying that they're not going to have the symptoms, they actually aren't, and it's saying that those that have the complicated, that are at chance for having the complicated alcohol withdrawal, they actually are ending up starting to get to that point. So it is very useful. So on the left, I have what the scale is. There's part A, part B. If they have consumed within the last 30 days, you do this patient interview, and then you also look at like vital signs and stuff like that, and then you score them. So score greater than or equal to 4 represents that the patient is high risk for moderate to severe or complicated alcohol withdrawal. 3 or less means that there's a decreased likelihood, but does not mean that certain monitoring should not be done. Like limitations to this would be if your patient obviously can't talk to you. You might be able to score a few things, but you're not going to be able to talk to them to see if they've had any of these symptoms or anything like that. On the right is a graph from one of the studies that I found. Most of the studies are ending up to be like this, but it breaks it down, and at the bottom you can see where it shows that threshold of 4, and it shows on the left with group A that 372 of the 374 never experienced alcohol withdrawal syndrome. And then group B shows that 27 of the 29 did end up experiencing complicated AWS. Now this does not say exactly, if they treated them or what but it does show that, and it does have pretty good percentages of predicting if a person's going to have alcohol withdrawal syndrome. Of course, with this comes education. You know, physicians need to be educated, nurses need to be educated. That communication gap needs to be fixed. But here's my references. Thank you guys for watching. If you have any questions, please comment below. Thank you.